My name is Dr. Kieran Mullen. I'm chair of the Western Local Commissioning Group. This is Mr. Paul Kavanagh, who's commissioning lead for the West. Essentially, the Local Commissioning Group is a subcommittee of the Health and Social Care Board. What we're really designed to do is, in simple terms, to give a local flavour to commissioning of health and social care. So it really comes down to us to give some sort of lead in terms of identifying the needs of the patient population in the West. We basically then would work closely with the Health and Social Care Board as part of the Health and Social Care Board to try and maximise the efficiency and the quality in terms of delivering care for patients right across the West, from the northern sector down to the southern sector. I'm also a practicing GP in Strabane, so I would access services across primary and secondary care, community and voluntary sector. So as my role as chair, it does give me a unique insight in terms of some of the work we would do at our local commissioning group meetings, work with the trust, work with the GP community and other stakeholders within the region or in the West to try and get the best possible outcomes for the resource we have in terms of delivering health and social care in the West. That's a brief overview of my role. Paul, do you want to maybe come in as well?
Sure. I suppose, I'm conscious just of some of the things that sort of listening to the previous session as well. We are part of a regional commissioning system, a system that has the Health and Social Care Board and the Public Health Agency working together. We then are a group that works locally in the West, but we're not just, I suppose, working with Western Trust. We're working with GPs, we're working with the other trusts indeed, because obviously we're involved in regional services, although largely those regional services are commissioned through the board centrally, but we would have obviously patients going there, so we have an interest to ensure that those services are actually provided to support our patients as much as other patients in Northern Ireland. I think our approach then is very much to be as regionally consistent as we can be across the region, and then to localise that based on the variations. As you'll have heard over your last few days in the West, the challenge of the geography and so on in the Western area are very, very different from parts of the East. Not completely different, but enough challenges to make it different. The challenges in Altnagelvin versus the challenges in the South West Hospital are also different. Challenges in Tyrone County as well different. So in terms of how we provide emergency care and urgent care, we do have to be as flexible as we can in relation to that, and some of the things that you heard from Joe in terms of the trust challenges of delivering those services when it is difficult to attract staff and so on, particularly very senior staff. Does mean that we are under pressure. There's no doubt about that. We're under pressure financially. We're under pressure, I think, from the point of view of delivering the service and sustaining the service. And we're also genuinely determined to ensure that these services are maintained going forward, even with all of those challenges. And I think the local commissioning group, which is made up of a broad church of people, and you may want to know more about that, there's a broad interest around the local commissioning group table. And I think a broad interest as well in the way that we work with the public and with clinicians and so on, in terms of understanding what people want from the services, of which emergency care is just one of a broad range of services which we must commission.
Okay, I'm going to go straight to Paul, and then...
First, gentlemen, thank you very much for finding time.
We
really appreciate it, and it's late in the day, and I think you were contacted relatively recently, so thank you very much for your forbearance and cooperation. Paul, on one of your last points, I would be grateful if you could educate me a bit about who the LGC is, who sits on it, and how it works.
Sure.
I've got some sense, but I'm sure you can help me deepen my understanding. Sure.
I suppose it's a mix of people both working within the commissioning system and also people with an interest in the commissioning system. So a number of the members, including Kieran, are GPs, practicing GPs. They have a day job, and they will come to us maybe a couple of times a month. So they're very much involved in their day-to-day work. We have a community pharmacist involved with us, 4 local government members, fairly well spread across our geography as well. We have a practicing dentist, a general dental practitioner. So quite a mix of people, and also 2 community and voluntary sector representatives as well, one from our northern area and one from our southern area. You probably have a sense that there's a northern-southern thing within the West as well. The geography, again, it's not surprising. So we try our best to try and have a bit of balance as well. We then will have people who are, as I say, officers within the Public Health Agency and the Health and Social Care Board. We have two social workers around the table, one with an interest in children's services, one with an interest in adult services. We have a public health doctor, an allied health professional commissioner, and I've probably forgotten a nurse commissioner as well. So quite a mix of people around the table, bringing professional sort of commissioning expertise to the table, but also bringing actually day-to-day work and a lot of contact, as you can imagine, with patients and service users amongst those people. So they bring a very different approach than people like me working every day in it. So I think they add a considerable amount of value from my point of view to the work that I have to do.
So some of the people in the local group are on the payroll of the commissioning board,
Mm-hmm.
and some are not, but presumably they get their expenses paid
Yeah,
or something
yeah.
like that. Yeah. And the voluntary sector representatives, I think you said there were 2?
There are.
Yeah, which sounds a good thing to me. How are they selected, appointed?
They're selected by interview, so we have a public trawl. I suppose the members we have at the moment have been members about 3 years, so it'll probably be another year or so before we'll have to trawl for furthers, but publicly advertised. And we also put it out. We have good relationships with our local community networks, so we tend to put things through them as well. So public advertisements in newspapers doesn't always catch people's attention. And then they're interviewed as standard, usually by myself and Kieran and 1 or 2 other sort of appropriate people, including our vice chair. Our vice chair at the moment is one of the voluntary sector members. So in that way, it's trying to have that bit of balance as well.
Okay. I mean, before I go on, I just wondered if Les or Marion wanted any clarification about those sort of almost constitutional matters about the LCG.
No, that's fine.
Just how many, are any of those people full-time, or just yourself?
The full-timers are people like, we have a social worker,
Yeah, but
2 social workers, they work for the Health and Social Care Board, but they then have 2 days a month that they provide to the LCG. Although they're involved in a lot of work I'm doing kind of on an ongoing basis. We'll have a public health doctor, works for the Public Health Agency, AHP, nurse consultants and so on, work for the Public Health Agency. So those people work full-time for the commissioning system, and then the others I mentioned then are working part-time.
On average, people do about 2 days a month with the LCG?
2 days a month, yeah, more or less.
But are you full-time?
I'm full-time, yes.
Thank you. Thank you.
Thanks very much. Just a big question, big picture question. I want to see if I'm understanding things correctly. If I understand it correctly, when the new health system arrangements were introduced in Northern Ireland, one of the aims was to drive productivity, efficiency and improvement through competition. I think if I read the books correctly, I think that was one of the ideas. However, I have the impression that the system hasn't quite functioned in a competitive way in practice, and it's become more like a system, and I'm not knocking it, I'm just trying to understand it, it's become more like a system for the sort of geographical allocation of monies. Have I got it correct, or could you disabuse me if I'm wrong, or could you elaborate? The essential point being that one of the ideas was this is going to be driven by competition, but I don't see that happening very much.
There's a degree of local services for local people. You would expect that.
Yeah.
You'd expect there to be geographic services. Otherwise, a lot of the services wouldn't make sense. But we do have services which are not provided in all of the 5 trusts, for example, orthopaedics being one that springs to mind. So we have an orthopaedic service based in Altnagelvin, which provides services to everyone in the Western Trust area, but also provides it to people in the northern part of the Northern Trust, the Old Causeway area. So you've services like that where it wouldn't make sense to have 5 services. They're too specialist, they require certain ways of working. So there's a bit of a mix of that. I mean, and one of the good examples in terms of trying to get the kind of the head around the issue of competition is actually ophthalmology services. So ophthalmology services in the Southern Trust area, they really struggle to recruit. And again, this problem of recruiting means the commissioners, we're pretty, there's not much we can do in terms of recruitment. You make the money available, you hope that the model makes sense, and you hope that people will come and take on the posts. Couldn't recruit to ophthalmology in the Southern Trust and Craigavon Hospital and so on. And what was decided was that the patients then would be re-provisioned in the two neighbouring trusts. Some patients on the eastern side of the southern area going to Belfast, some patients on the western side of the southern area coming to us in the west. We're looking at providing those services here in Omagh. So it's about, the reality is some of it is also driven by just the challenges of actually providing services at a local level. But I appreciate the point you're making in terms of competition, but I think the reality for the system is local services for local people, they must be provided at a local base, and our provider of choice is Health and Social Care Trusts.
So I'm not trying to put words in your mouth, I'm just trying to understand.
Sure.
So there's an element of competition, and you've given some examples, but it's not sort of primarily driven by competition between different, competing service providers within a
Sure.
a trust system. Is that correct?
Sure. Yeah.
Okay. Thanks. Look, I'm not going to repeat it all. I think you heard my questions about PPI and human rights and equality, and I am really interested in getting my head around this. Because on the one hand, I won't repeat it all, I promise, but on the one hand I do read the framework document, and there's paragraph, section 5, and it's really rather impressive, but some of it is very remarkably sort of elegantly written as well about the importance of participation. So there we have it, and some of those responsibilities fall upon the trusts. And then we also have, as we all know, the trusts have these really important human rights responsibilities. And equality responsibilities. So, as you heard me say, I'm puzzled how the trusts are meant to deliver these responsibilities when, if I understand it correctly, there isn't significant money provided by the commissioning board for those in discharge of those important responsibilities. So, maybe I'm missing something, but could you help me, please?
PPI is everyone's business.
Including the trust?
Including the trust, including my business.
Yeah.
I may not have a job title that says I am a PPI officer, but it is very much my business, and I'm keen to talk to you about some of the things we have been doing locally to support our PPI effort, but in trying to kind of focus on the question that you're asking. I think we accept that there's not specific pots that say this is the money that drives PPI, but our view is PPI is organisationally, corporately a necessity. We all should be involved in it, we all should be doing it, we all should have time within our jobs to actually undertake that. That's the approach that the Health and Social Care Board takes. Right. And to be honest, Western Trust and other trusts also are very committed and put a lot of time into PPI. Yeah. But I understand the point you're making in terms of dedicated monies and so on. In another time, we might have been able to provide that, but the reality is, given the pressures on frontline services, it is unlikely that we provide significant funds. There may be bits and pieces here and there, but it's unlikely we provide significant funds because our priority has to be on actually supporting the pressures on frontline services.
Can I just come on that, like as an LCG? Yeah, go ahead, sorry,
okay,
go ahead.
Go ahead.
No, well, the LCG, it's crucial to have the PPI aspect of that. This year we've engaged with our elderly population. We've had 1,000 voices where they've come to the LCG and presented various views on accessing health and social care across primary care, secondary care, including ED. We also have had effective engagement. Paul alluded to earlier our rural networks who engage with the LCG in terms of, again, experience of rurality, accessing various services. So we have reports on the engagement, and we would basically then, in our work with the trust, take the learning or the experience from these reports from people, users on the ground, patients on the ground, to allow us then to try and effectively mould service provision as best we can. So that we would see that as key to part of the LCG work as well.
Yeah, no, I understand that it's part of your responsibility, and I think I understand how you try to discharge it. And you referred to or Paul referred to the voluntary sector representatives, and I've read the Western Trust report on PPI, and it's doing quite a lot, but with nothing. Actually, that's not quite true. With £5,000 from the PHA. So I understand, but what you just said is absolutely right. I understand that, but it doesn't answer my question, because as I understand it, the trusts have these responsibilities.
Mm-hmm.
And yet they're not given a sou in order to discharge these responsibilities. And I just don't quite understand how that can be.
And as I say, it's the everyone's business.
But it's
Is
everyone's
all I
business.
can tell you, because I suppose I'm frank
But the
enough to
fact
say
is
there isn't.
it's not cost-free, right?
It isn't cost-free, but it's something that we do have to pay for, in the same way that the board doesn't have a particular pot of money that says for the things that we have to discharge, we don't have a PPI officer and so on, but it is all of our business. But it's a particular responsibility of people like me to ensure that the board does actually discharge that in a meaningful way. But I mean, there's a cost of booking rooms, there's the cost of transport and all those kind of things, and that's the kind of things that we would provide some of the funding for, which you've mentioned, because they're small amounts in the great scheme of things, but they can actually be very powerful in supporting involvement.
So, Paul, where are those little funds? Is that the PHA type
Well,
money,
it's
do
the
you mean?
PHA money.
Right.
We applied for the PHA money ourselves and didn't get any, but we were lucky enough to have some funding that we saved from primary care prescribing, where we were able to spend about 15,000 on some of the things that we did last year. Very powerful things in my view, including a major conference in
There's some good
Enniskillen.
stuff being done. I understand that. Okay, I won't go on. The human rights and equality, it's the same position, is it? So far we talk about PPI. I'm
Sure.
separating out, maybe I shouldn't,
Sure.
PPI and human rights and equality. So there are human rights and equality obligations.
We have
for trusts.
obligations, absolutely, as do we. Sorry, in the trust.
The trusts have obligations, but if they put a bid in, if some trust put a compelling case for, well, we take this stuff very seriously, there are statutory duties, and we need money in order to deliver them, then how would that, how's that likely to be received?
Well, it would be considered. I mean, it has to be considered. I mean, the trust can put forward a range of proposals and do. But I think until we actually issue what we call an investment proposal, there isn't money for it. So we would have to find the money for it. And having found the money for it, we would then ask the trust then to put it forward as a firm proposal which has the potential of being funded.
Right. So what was that phrase, investment?
Investment proposal.
So the commissioning board would have to be persuaded that something here they're willing
That's
to
right.
fund,
Yeah.
and then that there has to be an investment proposal, and then they notify all the trusts and say we've got this investment proposal.
No, not necessarily, because it comes from the West. The Western Trust can come to me and to Kieran and have a conversation locally.
Right.
So we may wish to make a local case,
I
and
see.
we may have access to funds locally to do it, or we may make a case centrally to try and gain some funds for the West only. Others may then, because my counterparts in other parts will also hear what we're doing, and they may decide that it's something they would like to do also.
Okay, last question. Thank you for your patience. You heard my question to Joe before, actually, and it's the same to you. I'm just trying to get a sense of how much room there is for variation, for a trust to supplement, deviate from the ministerial priorities. Is that the right word, priorities? Yes,
Yeah.
Ministerial priorities. I'm just trying to get a sense of whether or not really, this is it. And you can do the localizing, which is really important, and contextualizing, and that's of great importance and a great merit. But a trust doesn't have much scope to go beyond the ministerial priorities. Is that correct, or have I got the wrong end of the stick?
It's a fair question, and I understand the question, but the reality is ministerial priorities do not cover 100% of what happens within health and social care. It's the same thing, the point you were making about our local commissioning plan. It doesn't cover 100% of what is happening for the Western population. But I think the ministerial targets are where the greatest emphasis, let's say, both from a political point of view and also from a point of view of the public, because ministerial targets don't just come from politicians, they also come from what the public's aspirations are. So they tend to be given the most focus, and in turn, in some ways, given the most resource as well, certainly additional resource, to try and actually to deal with those issues. But I think it would be, in my view, simplistic to say that we are only doing things in relation to ministerial targets. I mean, one area that springs to mind, for example, is autism services. Not considerable targets around autism service, and yet it's an area that we in the West at the moment are trying to develop our services, particularly services for adults. So there's no ministerial drive on that, although there's lots of strategies, lots of policy. But you can see if we just did the targets, we'd be very limited in what we're trying to achieve.
Thank you, gentlemen.
Marion?
I just have one question. In terms of your investment proposals, do I take it that all the new monies are subject to the same size relation and the age profile of the population, that would be a comparable sort of money would have to go to the other trusts. The board cannot allocate money outside the capitation formula, is that right?
Remembering that we have no new money, just to be
but
on
if you
message, but
have new money,
but we certainly have what we call an equity review, which looks at the capitation formula across all of our programmes of care, hospital, non-acute and so on. And we ensure that we are largely in balance, and we are largely in balance across our various areas, with the southern area being a bit sort of out of sync given higher numbers of births. So we're very aware of where the kind of balance is. We are then looking at things like demographics, and we have different demographics, so we're trying to balance out a bit that if there's more younger people in this area and in the southern area, we don't need quite so much money in the younger people's side, but we need a bit more money in the older people's side. So there's a bit of balancing it out, which ultimately we have to net off against the capitation share. At this point, at a high level, we are at capitation share in the west, but I think once you drill down into that, it becomes a bit more. We could have more in this area, could have less in this area, and so on. And that then is the local circumstances that led us to particular services development.
That's fine, thank you very much.
I have two questions. First one, Paul O'Kieran, one of the issues that we've seen in every trust we've been to, we've heard different examples of quite good practice, and I think our sense is that not all of that rolls out across the piece, so that something might be going on very effectively in one trust doesn't necessarily automatically get rolled out in other trusts. Is that a fair conclusion to draw? And if not, how do you, in terms of commissioning, go, well, the Northern Trust is doing X, that seems to work, we really need to roll that out across the piece? How does that work in practice?
It's the sharing of good practice, and how effective is the sharing of good practice. I think we're fortunate in the West, because certainly we would have a very good relationship with the Trust. I would chair a TYC programme board that allows us to have discussions with the Trust about some of the developments around various specialties in care and changing care pathways. And certainly whenever we then, or when I would be at regional meetings, board meetings, or other LCG chairs, we basically have an opportunity then to say, well, what's happening on your patch? We can see also with a monthly update with the regional TYC programme board of some of the developments that are being brought to the regional piece from the various LCGs, things that have been tried and tested and work quite well. So that's the opportunity for sharing the information, but certainly locally we would have a fairly regular opportunity to sit down with the Trust to say, we have this care pathway, we have worked it out with these clinicians, GPs are on board, ED is on board, and we roll it out. And then ultimately then after a piece of time or a length of time to see how effective it's been from the point of view of the service users, the clinicians involved, other staff, that is something then could be brought to a regional piece if it's been effective. And certainly that has been the way, in the year that I'm in the job, that those regional meetings, been able to take examples of good practice from the West, that has been useful. We've been able to, at the last Health and Social Care Board meeting, which meets on a monthly basis, been able to give an LCG perspective as to things that have come on in the last year from the Western LCG. And it's basically the involvement with all stakeholders, from patients, clinicians, community involved in the sector, primary care, nursing, all right across the board. Whenever that has worked well, we've been able to do things. And the tight financial circumstances that we've been talking about, there still has been able to be effective progress. And certainly we have rolled out a lot of care pathways and things across the West. Altnagalvin certainly can be a priority because of the pressures that are in Altnagalvin, but we do have effective buy-in across that. And as I say, then using the regional meetings then to try and share that information as to what's worked well, what has been tried, what didn't work so well, and move on from that.
Can I ask you, perhaps give me an example of, both an example of something that's rolled out in the West that started somewhere else, you picked up from somewhere else and then ran with, and maybe also an example of something that initiated in the Western Trust that was picked up by other trusts?
Well, the one fundamental change, because it involves the ED that I'm aware of, and I was involved in the developing of the pathway, was the treatment of patients who have acquired deep venous thrombosis, which is a clot in their leg. Now, essentially, the management of the pathway of that patient involved assessment at ED to get access to a diagnostic, which was a scan. So we created a pathway where basically a patient could be seen in primary care. They could access the scan without attending the ED. So it was us, myself working with ED clinicians, working with medical colleagues and radiology, basically accessing the scan to basically see then if these patients can go straight for their scan and the GP can manage it, you're taking X amount of patients out of the ED per week, and that has been rolled out across the West. Now that has been looked at regionally. It's not accessible in every other trust. But it's working in this trust. It will be a part of the evaluation in terms of if this is something, and I think in the Northern Trust use it as well. It's about access to diagnostics and about making sure patients don't go into the ED if there's another way of treating them. In terms of pathways that we've used from other trusts, I'm trying to think, I've been put in the spot.
I mean, I'm conscious that we've developed a musculoskeletal pathway, which has been, I suppose, developed in a number of trusts, particularly actually in Britain. We've probably drawn more from some of the experience in some of the North of England trusts. And straightforwardly, that was trying to bring together a number of specialties: rheumatology, orthopaedics, physiotherapy, and so on, into a coherent pathway where, rather than your GP referring you to 2 and 3 different specialties, you're referred into one front door. And that front door then gets you to the right place as quickly as possible. Your diagnostics is at the front door, as opposed to when you get to the orthopaedic surgeon or get to a rheumatologist. And to be honest, we just stole somebody else's pathway because it was a very good pathway and it was straightforward to implement. Now in place, and we're beginning to see some of the benefit for it, and more importantly, patients are seeing the benefit of it.
I think, sorry to add to that as well. In terms, I heard Joe mention it earlier, in terms of the unscheduled piece, and it's a very much a historical thing in the West about this access to assessment in hospitals in terms of unscheduled care. And certainly when I was a junior doctor, whenever I was when I was receiving calls in the hospital, taking admissions direct from GPs, these patients did not go through an ED. They were being admitted for assessment to the wards. Now we have the acute medical unit, acute surgical assessment in both the northern and southern sector. This is about pathways into the hospital that don't need the ED. This, in my view, works very well in the West. And we have, as Joe mentioned, this openness in terms of accessing clinical specialists from primary care into secondary care. If I need advice on a certain specialty, I can get it. I can basically then have access to maybe a patient going into the acute medical unit for various diagnostics for quick turnaround that may not need then hospital bed days. And that, certainly in some of my regional work, that would be quite a foreign attitude, or that would be something that hasn't been in place for various trusts. But there has been discussions about that in terms of the merits of it. It works well in the West, as with any system, but where the flow is blocked, where there basically is less capacity in inpatient beds or whatever, that's whenever it can get into difficulty and where the ED can get backed up. But that would be an example I would see where if there's good flow management in terms of the unscheduled piece and patients moving through the system quite well, it works well in the West and seems to work well in the West, yeah.
Okay, final question for me. It's the first time I've heard the north-south-west divide, which is
in the West
an interesting concept. And I wondered, Kieran, in your position as a GP, as well as somebody who's very involved in kind of trust services, we heard about in terms of the South and the relationship with the southern side of the trust, the relationship with GPs, and how important that is with the emergency department, and how that same kind of relationship has not been developed between the northern side of the trust in terms of the emergency department. Have you any thoughts as to why you think that is, and how you might remedy that so that you have something as seamless in the north of the West as you have in the south of the West?
As I said earlier, it does seem to be historic. It's a culture thing. I think just there was this certain amount of joined up thinking between the primary care, secondary care interface. As I say, certainly from I was a junior doctor, it was very much about, if you're in primary care, having access to senior clinician advice and being able to work with that. Certainly the pathway work that's been done in the West over the last few years has involved sitting down with interested clinicians about, if we have this patient and this is how they're managed now, how could we do it better? How can we make it that they're not in hospital as long? How can we make it they don't sit in the ED as long? How can we make sure that they don't wait 2 days for their scan when they could have it in 1 day? It's about engagement. It really is about getting these people in a room to agree where, just what you had said earlier, about where there's examples of good practice or best practice, that what on earth would be stopping us from rolling it out in our area. And as I say, as local as if it works in the West, or doesn't work in the West and works somewhere else, how we can incorporate that in. So it's about people in the room, and I think it's our geography probably. There's a little bit of that parochialism, if you like, where basically, as I say, Joe was talking about the issues around recruitment. Most people who come to work in the West, if we can get the senior clinicians, they're here to stay. And the GPs, as I say, tend to be been here for quite a while and tend to be trained in this area. So everybody's familiar with the access and they're basically live to their patients' demand. So, I can have a meeting, 3 or 4 meetings a month with trust staff, and it's not confrontational. It's about what can we do different here. And as I say, certainly that to date has worked quite well, and we have good examples of it in the West.
Okay, thank you. Paul, I know you had one final question to...
Well, it's a final point, if I may, but if you wish to respond to it, please do, but it's very brief. Paul, you said, if I understood it correctly, you said that at this point no more money for PPI, equality, human rights, and the priority is frontline services. And I understand your position, but one point which I respectfully suggest is important. There is evidence that participation and human rights improve health interventions and improve health outcomes. And human rights, I suggest, are not something just to be sort of stuck onto an intervention. If integrated into an intervention, they can help to ensure the intervention has good quality and is equitable to all. So I suggest that if, this is bold, but I suggest that if human rights and emergency care had been considered together, some of the difficulties in emergency care that we're hearing about might have been avoided. So my essential point is that, as I see it, human rights can help health professionals achieve their professional objectives. And I hesitate at the sort of binary conceptual analysis of frontline interventions on the one hand, human rights on the other. They can be, and I suggest respectfully, should be integrated, and the health interventions would thereby be enhanced. But thank you again.
Can I respond?
Please.
Of course, yes. Yeah.
The point I'm purely making
Yep.
is that if a pot of money equals commitment, then we've missed the boat. What I'm saying is that it's everyone's business, and what we have to do is find ways to give people the capacity and the time, because it's not about capacity, but it's about time to actually do this. I do this work, Kieran does this work in the evenings after a long day, because it's worth doing. We from time to time bring others, clinicians and others, to those meetings. I mean, you haven't asked me about the things that the Western Local Commissioning Group has done around PPI, and we have quite a portfolio to talk about, including 1,000 older people who engaged with us through the local community networks, including talking about emergency care and their experiences of emergency care. Now, and we have already brought that to the Emergency Care Reform Group in Altnagelvin, which covers Altnagelvin and the South West Hospital. Kieran and I sit in that group, and we've made it very clear that there are things there that are worth considering and are being considered by the Trust with ourselves and with others. So, I at risk of being argumentative, and I don't mean to be, although Les knows me and I am a bit kind of, but I genuinely believe this is everyone's business. And why I appreciate that more resources could be, should be. The reality is they won't be, but that doesn't mean that we can stop it being everyone's business.
I would be really interested to see the portfolio that you refer to.
Sure.
I mean, my questions were directed at the trust.
Sure.
And time is short, so I didn't direct myself to your PPI work. But I have read about it, and certainly some of it I've greatly esteemed.
Yeah. But the good news and finishing is we've said to everybody who's given evidence to us that if there's additional material you can give us, be very welcome. I had picked up your first mention of you did a lot of PPI work right at the start, so I think we'd be particularly interested in getting some of that material.
Okay, and I'll certainly forward that to you.
Our impression is that actually the Western Health and Social Care Trust is ahead of the curve, and having read the local commissioning documents, not everybody has a PPI section in their local commissioning group, and the Western Trust does. So I think we've picked that up as well. So it'd be very helpful to have that. Thanks for coming. Another one of those out-of-hours pieces of work in terms of outreach. Is there anything you want to say just finally in terms of either haven't had an opportunity or before we just close this session?
I'm happy now.
I mean, to emphasise, we work hand in glove with Western Trust on emergency care issues. We're doing a lot to try and use the resources we have as wisely as we possibly can in difficult, straitened times. And I think Western Trust, and given that you've had Joe here, you've had Elaine here and so on, and others from the Trust, I think you get a sense of a trust and a commissioning group who are very committed to trying to deliver these services, Les. And I hope, we probably talk more about PPI than we do about equality and human rights. I see it as all the one thing anyway, but I would say that, wouldn't I? But genuinely that deep commitment of trying to engage with our public, because the challenge for us is for our public to use emergency care appropriately, and it isn't always appropriate, although admittedly it's difficult when you're feeling sick to know whether you're an emergency or an urgent. You'll have heard that before. But and on top of that, then for us to ensure that we actually can provide services in a very challenging environment, not just the money but also recruitment and all of those things that go with it.
I think my final comment, and Paul and the others will have heard it said, well, one of our challenges in this inquiry is that we've had a lot of evidence that actually what underpins what's being done implicitly is human rights and human rights concepts and principles and even occasionally international standards. And one of our challenges will be to try and see how that can be move from the implicit to the explicit in terms of how that's delivered. But thank you. I'm sorry we've kept you